We're Dr. Sandra Southard, Dr. Fern Webb, Dr. Juan Luque, and Dr. Lourdes Vazconde Garbonate, co-leads for the Community Outreach and Engagement Corps of the Florida, California Cancer Research, Education, and Engagement Health Equity Center. CaRE2 is a bicoastal cancer research and training center that brings together researchers from Florida A&M University, the University of Florida, and the University of Southern California.
We CaRE2 Health Equity Center is funded by the National Cancer Institute Center for Reducing Cancer Health Disparities. CaRE2 is committed to eliminating cancer health disparities and promoting health equity among Black, African American, and Hispano and Latino adults living in California and in Florida.
Our center focuses on 3 specific cancers: prostate cancer, pancreatic cancer, and lung cancer. We want to welcome you all who are listening to our We CaRE2 podcast.
Now we would like to introduce you to our host for this first season, Pastor Rhonda Holbert. She's a breast cancer survivor and an advocate, and the founder and CEO of the Celebrate Life Cancer Ministry, which is a nonprofit multicultural organization available to anyone affected by cancer and their families. Pastor Rhonda also serves as one of our CaRE2 Community Advisory Board members.
Hello, hello, hello. I am Pastor Rhonda Holbert, your host to the We CaRE2 podcast, as we explore the journey of resilience and triumph with Black cancer patients and survivors. In each episode, we'll delve into unique challenges faced by the Black communities in dealing with cancer and illuminate the intersection of race, health, and hope. And today we have with us Dr. Chanita Hughes Halbert, who will be sharing with you around the disparities in the cancer community for African Americans. Dr. Halbert, how are you today?
Good morning. I'm great. Thank you for having me on this important session. I'm so excited to be with you and have a conversation about cancer as it affects us in our communities.
You know, I've been working in the cancer community for about 22 years now. And as a survivor, as a cancer survivor, I was actually diagnosed with inflammatory breast cancer stage 3B, first mammogram, and my journey actually began on 9/11. And with that launched me into a totally new world, one I didn't know existed because cancer wasn't something that ran in my family. But now that I'm here, to be able to see the disparities, recognize what they are and try to find ways to overcome them has been a journey for me. And so, can you tell me the state of disparities within the Black community at this time?
Yeah, thank you. That's such an important question. And, we're so, grateful that you're here and that you're leading our efforts and working with many different partners across California, Southern California in particular, and that we are so honored to work in partnership with you as part of the CaRE2 Center. So one thing I want to just say, in thinking about cancer, we all, cancer is one of the leading causes of morbidity and mortality among adults in the United States, and it continues to be the second leading cause of death in the United States. And one of the things we know through work such as led by the American Cancer Society and by the National Cancer Institute, that there are important differences in risk of developing cancer, the likelihood of developing cancer, and the possibility and the risk for morbidity and mortality based on many different characteristics. And so we think about those as cancer health disparities, or the ways in which different groups that are defined by their racial background, their ethnicity, where they live, their geographic location, their residency, and other variables, sort of differences that are defined by those variables, are how we think about cancer health disparities. So disparities, is a really important topic. And, these disparities can occur when healthcare access and quality related to preventing cancer, early detection or screening, and treatment differ based on non-medical factors that include things like skin color, sexual orientation, and social variables. So we know through the efforts by the American Cancer Society and through the National Cancer Institute, among others, that African Americans have a greater risk of developing some types of cancers and, have an increased likelihood of morbidity and mortality. And so a couple of examples that I can share with you is that, for instance, for Black men have the overall highest cancer mortality rate compared to men from other groups. And so, if you think about Black men in general, that's a really, I think, important statistic. You also can think about that, though, for other individuals. So, disparities are not just limited to African Americans. Other racial and ethnic groups experience disparities. So, individuals from, American Indian and Alaska Native communities have the highest incidence of cancers of the kidney, liver, lung, bronchus, and cervix and colorectal. So I share that with you because I think it's important just to realize that, all groups have a risk of developing some type of cancer, but we do see very important differences based on racial and ethnic group. We see differences based on geographic location. We see differences based on social characteristics. So it's really important for us just to understand that, we all are at risk of developing cancer, but progress has been made, but there's still some differences and disparities that exist in our communities.
I was talking to someone the other day and they mentioned, I have been healthy all my life. I've tried to do the best that I can. I eat well. They don't eat, a lot of white products or sugar, and things like that. And yet they've still been diagnosed with cancer. So when we talk about, the risk of getting cancer, it's like, how do we get it anyway? What good is it to do right if I'm still at risk of getting cancer anyway? Is that a fair question? Is that something we can talk about? Or
Yeah, we can talk about it. I think that's a really important sort of way in which, I think it's really common, or an expected response or a typical response for, individuals who eat a healthy diet, they exercise regularly, they don't smoke, they don't drink, to, if they are diagnosed with cancer, say, well, why me? How did this happen? I did everything right. And so some of the things that I just want to say is that we often think about cancer in terms of risk factors. And what I think we're learning more about is, risk is, one of the things that how I think about risk is that, it's a likelihood. And so we all have some likelihood of developing, different types of conditions. So as we think about cancer and cancer health disparities, we can think about things along a continuum. So there's the behavioral aspects, so exercise, diet, smoking, alcohol, those are behaviors. And those are things that are we think about as modifiable risk factors. So those are the things we want to do to keep ourselves healthy, no matter what. And so, think about, one of the things that I think is an important area of research is, the likelihood of cancer outcomes, are sort of, the stage can be set based on our behaviors. But the other thing I think is important to keep in mind, there are other risk factors that come into play. So some of the work that's being done at the Norris Comprehensive Cancer Center, as well as other cancer centers across the country, is trying to understand the ways in which genetic variables, genetic factors contribute to one's risk of developing certain types of cancers. We also know that we're learning more about where we live, like our geographic location and the things that we're exposed to in our environment, play a role in developing cancer. So there are really many different types of variables or risk factors that lead to contribute to one's risk of developing disease. this is a really important time because we're learning more about how all of these different risk factors intersect and or work together to lead to the risk of developing cancer. So it's not just one thing, it's a lot of different things that are happening, all kind of at the same time a little bit. So it's a really, complex challenge for us to understand that.
Yes, and I think that's one that but we need to include more frequently in our conversation because we don't want people to get in a situation where they do all the behavioral things right, but they ignore the genetic and the hereditary, those kinds of other risk factors that are yet before them. So, I visited a hospital on the west side of town, and I'm gonna refrain from saying who, but it's a beautiful hospital. The services are great. I actually was part of a team that had a tour, and all this time, I never thought of myself as being wrapped up in the health disparities challenge. But on that day of that tour, I felt something that I'd never felt in my entire life. And tomorrow I will actually be 63 years old. I've never felt this. I never thought about it. I was raised in such a fashion that, like the temptation say, if you see something you want and you know you can't afford it, save for it. Figure out how to get what you need. So I never recognized the types of disparities that even I face. And in this hospital, they described a machine that's in the emergency room that when a patient comes in through emergency, there is something that will assess their entire system. And maybe two little hospital spaces down is a computer system that will access doctors, and these doctors on call could be anywhere in the United States. They could be able to get them the help that they need. It was at that instant that I felt that if I ever had a heart attack or something major, and I'm on in South LA, I don't even have time to get over there to get what I need. And it began to ask the question of, is it because do we have the equipment in South LA and nobody knows how to use it? Do we not have it because it costs too much? Do we not have it just because they didn't tell me about it? Right. So it's like all of a sudden I felt like part of this disparities challenge, right? And so my question is, how does healthcare play a role in the disparities observed in cancer diagnosis and treatment? Are we really sharing all the information we talk about? I was with some patients the other day and they were saying, well, nobody even offered me a clinical trial. Well, how do I know this is the best one, the only one?
Yeah, so first let me say happy birthday early.
Thank
That's,
you.
I hope you have something wonderful planned to celebrate your birthday. But what you're talking about, is really kind of one of the biggest sort of issues that I think we're finally confronting in a more open dialogue and conversation. And that's about how racism, structural racism, and discrimination influences many of the components in healthcare that ultimately lead to disparities. So the facility that you described, the issues with, whether or not there's a conversation about clinical trials, there's a conversation about this one type of, medication versus the other. We can trace that back to sort of the history of racism and discrimination in the United States. And I think, what has become more apparent is that the hospital and the care that you receive in one hospital can differ from, the care that you receive, in another hospital, just that are located pretty close together. I moved to California just a year and a half ago, and it strikes me that I think I understand what you're saying about where the West Side is located, but it's not too far geographically, from other parts of Los Angeles. Like in physical miles, it might be different, like based on, if you factor in traffic. But that's what you described is typical across all parts of the United States, where the hospitals that we are treated in There are very distinct differences in, the types of resources that are available, which ultimately influences the quality of care. And so quality of care is a really big factor in disparities, because it's not just about where you go, but it's the type of care you receive once you get there. And so some of that is, and that's based on the technology that exists in the facility, but it also can be what and how providers talk to you and provide information to you. So those are the things that where there's a significant focus in just understanding that, and really disentangling how structural racism, which is a huge history in the United States. I mean, huge history. I think we all know that it exists, it continues to exist, and it has really has had these, long-term effects that we're just now beginning to understand through research that's being done, again, across the country. So that's where we're starting to now have conversations about social determinants of health, because it's sort of the big umbrella for how we think about and understand where and how we live, where and how we receive healthcare, where and how we receive cancer screening and treatment influences the course of the trajectory of outcomes following diagnosis and treatment. Social determinants of health also influences, some of those behavioral things that we talked about. So, living in communities that are sort of described as food deserts, reduces one's ability to eat a healthy diet. It reduces one's ability to exercise regularly. I think, we now have a better understanding of that. But what I think is really important is that, we have to understand what exists in our communities that are assets, because we can always find things that are wrong and things that need to be improved. But the question that I think is where we need to kind of turn our attention to is well, how is it that even within these sort of, adverse, social conditions, like these challenging social conditions, there are ways in which folks can be resilient as we sort of have our conversations about disparities, because we want to understand how we can achieve equity. And one of the ways in which we can achieve equity is certainly understanding the ways in which, the social conditions, structural racism influences the healthcare access and healthcare quality. But we also have power, and we can sort of build our collective power to advocate for things that we know and see need to be changed.
That's good, because all of this whole conversation on health disparities is like an octopus, and there are many legs to it, many different perspectives, many different angles, and even each of the legs has its own tentacles for us to hang on to, or that get stuck to us, or whatever the case might be. So surely we're definitely touching on a lot of things that are important. And because we recognize that the system is the way that it is, how can community organizations or leaders play a role in advocating for better cancer care?
Yeah, that's a great question. And I'll start that by saying one of the ways in which we sort of are working to enhance equity, I think we all have a part to play. So, researchers have an important role in trying to understand how, living in areas that have high levels of segregation, for instance, where and how that's associated with racial disparities in breast cancer survival. And that's really important because it helps to provide, the empirical data, the evidence that enables policymakers, community groups, clinicians, researchers, those of us who are sort of working and sitting at the table to develop more effective systems and processes. So that's really important, the research component. But I think the other thing that I want to emphasize is that, part of my own research program is really about how to empower individuals within communities and community groups. Some of that is just understanding what the challenge is, what the problem is, and then working really with community partners and organizations to say, well, what would you want to see happen? What do you think needs to change in this scenario to really to improve things. The skills that, someone like me and a researcher brings to the table, sort of understanding what evidence shows, what can be sort of addressed. But I think we have to work in partnership with community organizations, patients, and other advocates to say, well, how should we change it? What needs to be changed in a way that's sustainable? And so one of the foundational aspects of my work and the work at Norris at the University of Southern California is really to begin having these conversations and dialogue with patient advocates and with community-based organizations and public health entities to really say, well, what can we do? What do we need to do? And how can we all contribute our expertise to making sure that those changes are made in a way that's sustainable, and that meets the needs of all of our community groups. So advocacy is critically important. And I would just say, based on my experience, we have to begin. The group that I think has been missing from this conversation are elected officials, to be quite honest, because our
Right.
elected officials are the ones who will sort of make decisions about how resources are allocated at the local level, at the state level, and then at the national level. One really great example of that is, the White House has like several different sort of aspects of what they're calling a moonshot, cancer moonshot. And as part of that, they have really moved the needle as it relates to patient navigation. And so as a result of sort of mandating now that patient navigation services, which we know is an evidence-based approach for addressing individual level characteristics or patient level barriers to kind of progressing through getting the diagnostic care, getting cancer treatment, getting the other services that are needed as part of one's cancer journey, is now reimbursable. And so what that has done is, taken a sort of an intervention approach, a strategy that's been developed and evaluated through many different, cycles of research, many all across the country, that has now sort of at the federal level said, this is something that will be reimbursed. And so, how it's reimbursed, I think, is still being determined. But because the federal government, the national level has gotten involved, that now creates the opportunity to say, we have nurse navigators at Norris, but now it's like, okay, so we can begin to sort of say, well, we can get reimbursed for that service. Nurses can be reimbursed. So healthcare systems, I think what I hope is that they'll be more willing to invest in those services, because we know that patient navigation is effective and in helping individuals get the cancer care that they need. So that's kind of like where I think we can, who's missing from the table in my mind is the elected officials, because they need to kind of understand, the landscape and where and how health and healthcare is a priority for our communities, and where those investments need to be made and resources need to be allocated. So that's my opinion.
So that's really good. And I'm so happy to hear the importance of getting the participant, the patient, the family's perspective on what is needed on this journey. Being a 22-year cancer survivor myself, no one's really ever asked me what is needed as a patient, because I'm involved in various community organization, collaborative committees and that kind of thing. I'm at the table, but the average person is not. And things are changing over time. From one of the people part of Celebrate Life Cancer Ministry, she says, I've been surviving this thing for 45 years. And when I got started, that all they did was a radical mastectomy. Well, there are a lot of choices now. Things have changed, things have evolved. And it's important for us to recognize, even today from a month ago, is there anything that can be done differently? And I'm sorry, I keep going back to the system, because I'm actually supporting a family member in another state, and it seems to be duplicating the same kinds of disparities here in another state that are taking place in Los Angeles. So it just brings me to the point of we've spent so much time educating on mammograms. And now the number of people who get mammograms on a regular basis has increased and has improved, and things are getting better as far as the mortality for African American women along that line. So when we talk about, what can community organizations do, I would also think a new level of education might be necessary, a new direction of education.
I think you're absolutely right. I mean, I feel like, in my mind, in my view, one of the things that's so important is that, we have to understand sort of when we should do things, how we should do things with respect to cancer screening, early detection. We also, and I think, those that, there's been a huge amount of collective engagement and improving knowledge and awareness about mammography for women. There's a greater effort now, I think, being focused on improving knowledge and awareness about colon cancer screening. And so, the thing that strikes me is that things happen over time and we don't see change until, you know, we have to kind of take a moment and pause and sort of say, well, we were here, now we're here. And
Right.
so, I think mammography is a really great example because, there was a time when, women didn't know that we needed to get a mammogram and the guidelines were evolving and changing. And now we can look back, I think, at this point in time and say, oh, well, we've moved from this rate of screening with mammography to this rate of screening. But now what we're trying to understand is that how should the guidelines be modified for women based on? So we already know about family health history, so that women who have a family health history of breast cancer may need to have, a different screening interval than women who don't have one, because and depending on the significance of the family health history, then those are the things that, doctors should be talking to women about. It's like, well, what's the best sort of individualized a screening interval for you based on your family health history and other characteristics. That's where genetics comes into play. So we know now that there are at least two breast cancer susceptibility genes that contribute to a woman's risk of developing breast cancer. And if there's a history of a mutation in one's family, that will influence the screening intervals that are recommended. So the question is, do we all know that? Do all women know that? Do all women have access to that information? I think there's tremendous improvement has been made about, women knowing about some of the basic, like you need to be screened, starting at the recommended ages. What I think we still have work to do though, is like, what do you need to do next if you find that you have an abnormal result? What are sort of the next steps in the sequence, and how can we, talk to our healthcare providers and ask the questions that we need to have a good understanding about so that we can make good decisions about our care and make informed decisions about our care. So I think those are the things that we need to understand better. At the same time, there's the investment in cancer research is sort of coming to fruition now is, we know that, women who have a family health history of BRCA1 or BRCA2 mutations, which are the two cancer susceptibility genes, that those are the things that, can inform and enhance our decisions. So I have a family health history of breast cancer. My mother was diagnosed before she was 50. She was diagnosed at age 32, which is a really early onset diagnosis. And so, having that conversation, having that knowledge, of my family health history has been important to, helping me have conversations with providers about when and how I should be screened. And I think that raises another point that I just want to make is, one of the things that is so important is that we have to, within our families, have these conversations about our history. I'm not saying we have to share
Amen to
everything.
that.
We don't have to share everything, but we do have to share something. So cancer is one of those things that we have to share, that, if we've been diagnosed, if we had like an abnormal screening, if we've had like biopsies, those are the things that we have to kind of feel comfortable talking about in our own families. We don't have to share all our business, but we do have to share a little bit.
That's really good. I was with my family not too long ago, and it dawned on me as I was sitting and looking, from my generation, there's only a couple more still with us. And when I look at the fact that I am the oldest granddaughter on one side and the only granddaughter in this generation on another side, I sat back looking at life a little differently, and I was like, oh my goodness, every time we get together, we have a great time, but nobody's talking about important stuff. And we're not, we come from a generations where you don't talk about the C word, you don't talk about this, you don't talk about that, to not even passing that down, but because it wasn't talked about then, it's just not talked about now. So we need to begin to instill, let's talk about it. I saw a magazine the other day that reminded me of Joan Rivers. Can we talk?
Yes.
We just need to talk about a lot of things with health being on the top, especially when cancer is something that is prevalent. I don't want to say it's running through my family because somebody needs to stop the runner, right? But it's prevalent in our family. And regardless of what type of cancer it is, this conversation is not around a specific cancer. So we don't want to say, oh, it's only breast cancer or prostate cancer or lung or colon. Those are the ones that we can do something about faster, right? But there aren't necessarily prevention tests. What's that called? Screenings that would help us to be able to identify others unless you have symptoms, right?
Right.
But if it's something that is prevalent in your family, to be able to communicate that with your doctors is so, so, so important.
So I want to share with you another example because, one thing that strikes me is these conversations that we need to have in our families. So, and I think it's so important because, when we were talking about people sort of doing the right things, not smoking, not drinking, and still developing cancer. So one of the things that it made me think of my grandfather who passed away from lung cancer, not a smoker. And he actually had, lung cancer screening in the VA. He was a veteran, and so he has cancer screening in the VA. And he died from lung cancer. And as we were going through his papers, we found like the letter from the VA saying that he had an abnormal screening result from lung cancer screening. He needs to come back in to have some follow-up care. So we found it in his papers, as we were sort of going through getting ready for his service. And I was like, and I asked my grandmother, I said, well, did you know he had lung cancer screening? She's like, no, I didn't know he had lung cancer screening. Did you know then I was like, it doesn't make any sense to ask the next question. Did you know he had, but I asked it anyway. She said, no, I didn't know. I said, well, so the question, we'll never know the answer to, but it just kind of made me wonder why he didn't tell anybody that he had like I think in the VA, they have, I don't know how he sort of got it because he's not a smoker, but so I guess I was like, well, what happened here that you know, led him to the course of getting screened for lung cancer, and then, more importantly, that he got results that were abnormal and didn't tell us, didn't tell anybody. And so just to emphasize the point that we have to be able to talk to each other. We have to be able to talk in our families and talk in our extended families about what we're going through so that we can take the steps but to make sure that we get the next thing and that we need.
And it may not start with telling, at the family reunion.
For real, right?
It may
So
start with just telling that one that you can trust, and then having that conversation of how do we unfold this information out to the rest of the family. It might be as simple as doing a survey, a no-name survey that's just for your family. So have any of these health conditions affected you? Have you ever, even to how have they been cared for at the hospital? Have you ever felt, you know, um, not treated correctly? Have you ever felt, whatever these surveys that we give as part of research? Maybe we just need to develop one that we could share within our family.
That's a great idea. There used to be like a family, health history reunion many years ago. I think it was in Washington, D.C. And I think, we're now at a point where we can start thinking about that because as you were talking and as we're having our conversation today, social determinants of health is, it's sort of been focused on around, where you live and the extent to which, there's a history of segregation or racism in your particular neighborhood or community. The other thing about social determinants of health that I think is just important is, social connections and isolation and perceived stress. Because, the things that and how our connections to others and our level of comfort with talking and, sort of using our connections in a way that will be impactful and meaningful for our health is something that I think we have to pay more attention to. So social isolation, just to kind of give some statistics, is defined in a couple of ways. One is the size of your network. So how many people do you know that you can talk to regularly, that we can engage with and receive and provide information to. So that's one way of thinking about social connections. The other way is like your perceptions of the quality of those relationships. So do you feel comfortable? Do you feel lonely? Do you feel like there are people that you can reach out to? That's the other kind of aspect of like social connections. And what we know about social isolation and as one particular manifestation of connections is that that's a huge risk factor for morbidity and mortality. So not having people in your network, people that you can talk to, people that you're connected to, plays a role in, our sort of healthcare, our health and the quality of care, and sort of our risk of developing diseases and our risk of morbidity and mortality. So it's important for us to begin thinking about how we can build upon, I think, our community resources where we do come together and we do have connections. And the African American community in particular, there's been a lot of work done within faith-based organizations or churches, because that's one of the places where we come together. We have like strong connections through our churches, through our and that's something where I think we continues to be an important resource, but we have to think about how we can build upon that and use it as a way to enhance connectivity, within our communities. The other sort of aspect of social determinants of health is perceived is like our stress, right? I was a new faculty member at the University of Pennsylvania, and I was doing work trying to, understand experiences among African American breast cancer survivors, really trying to think about, well, what can we do to enhance quality of life following their diagnosis and treatment? And, one of the questions that I'll never forget it because it made such an impression, the whole conversation did, but one of the things that, struck me in talking to women was that and these are Black women who had breast cancer, who were survivors, who had survived their, diagnosis and treatment. And, one of the things that, the participants shared with me was that stress caused breast cancer. It was her belief that stress caused breast cancer. And I was like, well, that's an interesting view. And, she went on to say, in the conversation, the other kind of key points were that, I have a lot of things to deal with in my life. Cancer is just one of them. And so I was like, well, that's a whole different experience than, what had been reported in the literature where, cancer for I think for all people is a life-changing experience. But she's like, I have a lot of things to deal with in my life, and cancer is just one of them. So it's a very different experience, right? So fast forward to maybe 2005, there were studies that were done which illustrated that, in some of the ways in which, research is done, is you first do research, in a way that we can really sort of identify and isolate the particular sort of biological, physiological mechanisms to understand disease process. And so this group at the University of Chicago did a study about social isolation. Rats are animals that are very social. They live in communities. They kind of like have to be together. And that enhances their survival. So what they found through these animal studies was that the animals that were socially isolated, like physically isolated, had a greater likelihood of developing mammary tumors that were histologically, that had the same characteristics that tend to be diagnosed among Black women. And so raised the question around like, and it was like the rats were like stressed out. So they were like experiencing stress, and being socially isolated was like the stressor. So now we sort of think about it as, stress is, we all kind of have stress in our lives. Everybody can experience stress. And so it has a profound effect on all of our physiological symptoms. And research is being done now to really understand. It kind of ties us back to structural racism and discrimination, because if you live in areas that may not have like adequate food resources, adequate places to exercise, there's crime, police interactions, all of those things are like stressors. And so it's sort of like, well, if you live in sort of a state where there's like chronic, like, the fight or flight response, everybody does, everyone has it. So the typical, you experience a stressor, like a acute stressor, you kind of increase in cortisol, and then the cortisol should go down after the stress is mitigated. But if you live in an environment or live in situations where you're always like, my family would say, you're on 10 right now, bring it down. Bring it down. You're always at 10, that's like just makes your body have more wear and tear. And so we're trying to really understand that now, because, as a sort of how stress and chronic exposure to stress influences like the sort of your overall physical state in terms of your wear and tear. And that's where I think we can sort of, have an impact, because one is sort of taking like a very important sort of social determinant of health and making it so that we can understand that at an individual level, but also at a group level, because we know that where and how you live influences your chronic stress exposure. But there are things that we can do about that.
Right. Right. And so, I tend to be a defender of doctors. And I don't completely understand why I do that, but I tend to do that. And one thing that I often hear is the doctor should have told me. And then my immediate response on the inside is yes, but the patient should have asked. Because yes, the doctors are the healthcare professional. I get that. And however, they see a lot of patients a day. And I'm one of those people. I actually conduct orientations for entrepreneurs on a regular basis. And I have a tendency to think I already told you because I've said kind of the same thing all day long, right? And I remember when I was diagnosed, and my doctor, I thought we had a great meeting. She was very informative. And I get home and she called and I panicked. And I'm like, okay, what's wrong? She said, oh, I forgot. You are at the age of still being able to bear children. Is that something that's important to you? Right. And so that was an additional conversation that we had. But in her humanity, she realized that she didn't ask me that. And she said, a lot of my patients are 60 and over, and you're just 40. So that's another question that I needed to ask you, different from someone else. And that takes me back to where I said we need to educate our community on a different level, onto some different things to begin to make the same kind of impact that we made getting Screen with Member. And that brings me to my next question, which is how can we ensure equitable participation and representation in research studies and clinical trials? Recognizing that half of us still complain about something historical. Another group of us don't know at all. And then some of us are just hanging on to what somebody else already said. But how can we bring this knowledge and education to people and so that they can begin to be parts of trials?
So I think this is, an important discussion because, one of the, and I will say, there are probably sort of two ways to think about it. So one, I do think, our providers have to do a better job of talking to patients, initiating discussions and conversations about clinical trials with patients. And there are systematic things that, I think can be changed and how the conversation about clinical trials is introduced as part of cancer care. So, what happens now is, and you can tell me if you agree with this, but clinical trials are presented typically at a point where standard of care has been tried and may not have had the desired results. And so it's presented as sort of like one of the last options. But when
Yes,
really
I
clinical trials can be a part of one's cancer journey and cancer treatment, and that way I think from a system perspective, we need to start having conversations about clinical trials earlier in the diagnostic phase, so it's not sort of presented as all things have failed, we're now going to offer you this clinical trial as like our last ditch effort. So I think that's what the healthcare systems and the providers within the systems can and should. I think that's an important thing to sort of think about how to do that in a way that will sort of change the model. I also think that, patients sort of all relationships involve like minimum two people, right? So providers have their role and responsibility as being the sort of the representation of the healthcare system. Similarly, we as patients have a responsibility to understand, that clinical trials are something that are an option for us. And we should sort of understand all of our options as part. And this is where the social connections, because I think, as someone is newly diagnosed, you're just thinking about how you're going to get through these next couple of key decisions that need to be made. This is where you need to have like an advocate sort of thinking about the cancer journey and sort of being like the one who's like helping you think through and understand what the resources are. That can be a navigator and the healthcare system, but it's really about making sure that we understand the full range of options that might be available to us, that are available to us. And if your provider doesn't raise it, we can ask the question. We don't have to wait for the provider to say, hey, have you thought about this? We can start asking the questions. And I personally, I started, really thinking about that when I became a mother, because then it's like, I want to know everything that's available to me that I need to understand to make the best decisions for my children possible. And I think, we can ask the questions and we can, we don't have to wait.
exactly. When it comes to talking about researching studies and clinical trials, there are a number of different kinds. There are educational clinical trials, research projects. Everything doesn't include giving blood or urine or whatever the case might be. And everything doesn't have to be right in the midst of all that's going on. The other is that when you're in a clinical trial, a lot of times people have been trained to think that either they're not treating you, they're giving you sugar water, or they're giving you the real deal.
Mm-hmm.
But in the cancer world, that's not how it goes. You either get standard of care or you get the new treatment, right? Am I right with that?
Yes, I think that is correct. Yeah.
And so, in doing that, again, there's just so much education that is great if you could get it ahead of time. But to be able to ask for a navigator, to ask for, who is the social worker. These are things that people aren't told. You have an oncologist, but the oncologist is different from the radiologist. These two doctors may be giving you something for pain if you have chronic pain or a consistent pain, but yet there's still a pain management department, right, that specifies, just concentrating on the pain itself, while the others can take care of the oncology, the cancer, or the radiation treatment therapy. So there's so many pieces to this cancer world. And then there's still, the psychosocial part. And
Absolutely.
in the midst of all the disparities, we don't have this, we don't have access to this, we don't have access to this. But if we're educated, we can begin to carve out a space so that we can begin advancing through this journey, because it is a continuum of care. It is a journey. We're not going to stay in one place. We continue to move from where we are to the next place, to the next place, to the next place. And all of that is also important on the lives of the people that we care and support.
Absolutely.
Wow, this has been a great conversation, Dr. Chanita.
Well, thank you, Pastor Rhonda. Pastor Rhonda, it's been a great conversation with you. Thank you so much for inviting me and having me on the podcast.
Thank you so much for being here. And as we leave this conversation, again, we are a CaRE2 podcast. And until next time, choose